The premier event for infection prevention and control is coming to San Antonio this June. APIC's annual conference brings you the latest research, innovative products, and practical knowledge to help you prevent infection. From inspiring keynotes to thought-provoking panel discussions, APIC 24 curates an extraordinary platform for knowledge exchange. Meet IPs from around the world who face the same daily challenges as you. If you work in infection prevention and control, you don't want to miss this event. Learn more and register to join us, in person or virtually, at annual.apic.org.
You're listening to the 5-Second Rule, brought to you by APIC, the Association for Professionals in Infection Control and Epidemiology. Together with our nearly 16,000 members, we strive to create a safer world through the prevention of infection. Join us while we talk to infection preventionists and other experts to learn the truth about some common myths related to the risk of infection and to get tips to keep yourself and the people around you safe from infection. Hey, welcome back, everybody, to another episode of APIC's The 5-Second Rule. I'm Silvia Quevedo, your host, and this episode is all about infection prevention and control with emergency medical services. I bet a lot of you don't even think about this, but, how prepared are your EMS and EMT folks when they go out and rescue you from a disaster or maybe a medical emergency? So to help us understand all of the intricacies of this, we have Jill Holdsworth, who is manager of infection prevention and control at the Emory-University Hospital Midtown. Jill is a very active member here at APIC, and she was the 2015-16 APIC Emergency Management Committee chairwoman. And she currently serves with the Association for the Advancement of Medical Instrumentation Protective Barriers Committee co-chair. Jill's a certified EMT, emergency medical technician, and she's certified in sterile processing. So welcome, Jill.
Thank you. Glad to be here.
Jill, did I get that right? You're a certified EMT, that's emergency medical technician. Is that correct?
Yep, that is correct. And I actually became an EMT after I was in IP in my spare time.
Oh my God, more letters after the name. And also joining us is Dr. Alexander Isakov, who is the director of the section of Prehospital and Disaster Medicine at Emory-University School of Medicine. And he is also the founding executive director of the Office of Critical Event Preparedness and Response, otherwise known as CPAR. And he's also a professor of emergency medicine at Emory University. Welcome, Dr. Alex Isakov.
Thank you, Sylvia. Good to be with you. And always good to be with you too, Jill.
So I want you both to sort of help our listeners understand all about infection prevention and control with EMS. So I'm going to start with you, Jill. I think it's important to set the stage in terms of understanding who we're talking about when we're talking about emergency medical services. Who are these people?
Sure. No, it's a great question. And I will kind of start on the other side of things, kind of taking off my IP hat and speaking along the lines of me as the EMT. And it's interesting when you are on the other side of it and thinking about being the person inside the ambulance, jumping out of bed in the middle of the night and trying to remember everything half awake, and being an EMT going into homes that you don't know what you're walking into, or picking up somebody on the side of the street, or, at the MARTA station, anywhere is where you're responding to. It's not like being in the hospital where you are a little bit more prepared for what you're walking into. When you're a first responder, you're walking into unknown situations. So you have to be prepared for anything. So understanding how to protect yourself, how to put on PPE, what PPE you might need to have available, how to clean up after certain things, all of those things are really important, but first responders may not have the same resources that we have in the hospitals to educate and teach and train. And as an EMT, we didn't really have those same types of resources to teach us. And
well, let me stop you, Jill. Because there's a lot there,
sure.
and we're going to have to unpack it all. But there's a lot here. But we're talking about first responders, so people who work for a fire department, an ambulance, or medical transport. Would that be accurate?
That's absolutely accurate. Anybody who, and we have a lot of medical transport folks that are bringing people to our hospitals who might even be transporting from or to a nursing home or subacute. It's people responding to emergencies and transferring them to our emergency departments, or like you mentioned, it could also be a firefighter who's responding to an emergency, because they also are giving first aid and basic EMS services. So it could be a wide variety of team members that makes up the emergency services.
Okay. I just want to make sure people understand who we're talking about, because those same individuals, the amount of training in infection prevention and control might be varied. So yeah, you dial 911 or you're at a long-term care facility and you need transport. These are the folks we're talking about. What I want to get into, and you alluded to this, Jill, is obviously, let's talk a little bit about training. In your experience, how much training is available to EMS folks in terms of infection prevention and control? Is this something that is part of the curriculum when you're, studying to be that person? Or is it on-the-job training?
There's a little bit of
both. Or maybe you don't know.
And it depends on where you are and what kind of training you're going through. Pre-pandemic, I'm sure, is different from post-pandemic. I'm sure there's a lot more PPE training now and what everyone went through with the
pandemic. And
pandemic.
By that, we mean personal protective equipment.
Yeah, correct. Thank you. Before the pandemic, everyone had, of course, a basic level of required training that we all had to go through in EMS. We all had to learn what we needed gloves for, what we needed a gown for, what we might need to put on a mask for. And of course, that has all changed, with COVID. But I can remember getting out of the ambulance. We were always told, put your gloves on when you get out of the ambulance. And we left them on all the way until we got to the hospital. So it makes me cringe now thinking about that, but we left it on getting out of the ambulance, going to get to the patient, coming back into the ambulance, going into the hospital, and then we took it off. And to me now that makes me just almost sick to think I left my gloves on that many times without changing them. But we also kept gloves in a little holster on our belts. We kept 3 pairs of extra gloves in case something else happened when we responded. And we knew to change our gloves if they got soiled, but we didn't get in-depth training that maybe an IP would have given to somebody. And I think maybe that's needed. Some jurisdictions have dedicated infection control officers. Some of the areas that I've worked with, to where they get a little bit more training on what kinds of infectious agents you might run into, what symptoms to look for, and what you might need to protect yourself. And that's been really interesting to see the differences in different counties and states.
Okay. So, Alex, Dr. Isakov, you obviously being the founding executive director of the Office of Critical Event Preparedness and Response, what are your thoughts on the training? And obviously there's a lot here, right? So there's the knowledge of, fundamental basic infection prevention and control practices, everything from hand hygiene to how to, put on and take off gowns, gloves, masks, etc. What are you seeing in terms of the training or gaps that might exist in infection prevention and control with this group, with first responders and EMT?
Yeah, thanks, Silvia. If I could, I'm going to expand the definition of EMS just
Great.
a little bit. It certainly includes the first responders that we've been addressing, that Jill described. But it also includes EMTs, paramedics, nurses, sometimes physicians that are involved in interfacility transports, from one hospital to the other. Often these are critical care transport teams, teams that are working within a framework where you have referral hospitals that will take your trauma patients, your critically ill patients, your burn patients from community hospitals to referral hospitals. And so I'll expand the group of professionals that are involved in what we kind of broadly describe as EMS to include that group as well. Whether you're an EMT or a paramedic or a nurse, or a physician, you get some basic education and training on standard precautions. So a lot of what you'd mentioned, Silvia, the hand hygiene, how to handle sharps properly, the importance of the use of gloves, the importance of the use of eye protection and other components of a personal protective ensemble to prevent exposure to infectious bodily fluids. And you get basic education also in transmission-based precautions. So if you're aware of a patient that requires additional protection because of the illness that they have. So it could be a patient with methicillin-resistant Staph aureus, for which we know in addition to standard precautions, you need to apply some contact precautions. Or a patient who has a pneumonia, for example, where we know that heavy droplets can transmit that illness. And so you need to apply standard plus droplet precautions. Or a patient with tuberculosis or COVID-19, where you need to apply an N90 fit-tested, NIOSH-approved N95 respirator and other measures that are important.
Thank you for qualifying that, by the way.
Airborne transmission precautions, right. I think the issue for the EMS community, but probably for all of us in healthcare, is that whatever you learn in that initial education program, those competencies and proficiencies, they tend to wane. And depending on the culture, right, in which you work, you're either applying them very meticulously or you're not. Depending on the patients that you're caring for and the illnesses that they might harbor, obviously the stakes can be pretty high, in that regard. I think what we learn about standard and transmission-based precautions is important for protecting us as healthcare personnel, whether we're EMTs, paramedics, nurses, or physicians. But it's also important for the protection of other patients that we interact with. We don't want to be carriers of a communicable disease on our articles of clothing or on our equipment, that if we don't properly clean it and disinfect it, then we put other patients we care for at risk. And so clearly some type of refresher training is required. And I think also an additional education to sort of emphasize the importance of why these standard and transmission-based precautions are so critical.
So Jill, that's helpful. Jill started to talk a little bit about this. I mean, obviously you don't know what these individuals have, right? So do you walk into those situations, a 911 call, it's an unknown, right? You don't know what the person has. It's a 911 call with a suspected heart attack, but that person could have other things going on. So, that's a unique challenge. As Jill said, it's not a controlled environment. So I'm also curious about how first responders manage, the equipment, the ambulance. Now, correct me if I'm wrong, Jill. I've heard that, ambulances can be kind of, nasty. I mean, is that a rumor that I've heard, that there, surfaces and equipment within the ambulance? And I'm fortunate to say I've never actually been in one. Am I making that up, or is that a thing?
I think it's certainly
Jill?
possible. But like we know, you can't see bacteria and viruses. So how would you know? I have been unfortunate enough to be in an ambulance as a patient, and I can say that's probably not the first thing that you're thinking about as a patient riding in the back of an ambulance. But I will say one thing that I did as an IP back in Northern Virginia, we had a great partnership with our local EMS agencies. And one thing that we did, which was super cool, we took the bioluminescence gel that we use here in the hospital for EVS that glows under the black light, and we took it to some of our local EMS agencies. And we didn't do it everywhere, but we used it as an example, took videos and pictures, and we put it all over the inside of the ambulance. And then we asked their normal crews to come clean it like they would after a call. And we didn't tell them why. We just told them to clean it like normal. And then we used the black light all over the inside and showed them all of the high touch areas that they missed, just like we would, a patient room for EVS. And we use that as an example for teaching. And, we didn't have to do that. By no means is an IP in charge of all of the area EMS agencies. But in the long run, it's great to help your community like that. They're bringing you the patients that could potentially have picked up a bacteria or virus on the way. So it's great to do things like that if you're able. And that's a really simple way to teach people how to clean properly. As the EMT who used to clean the ambulance, I'm sure I didn't do a great job, because you're rushing off to the next call. As soon as you put yourself back in service, you're not thinking about cleaning those high touch areas. You're thinking about making sure you grabbed all of the supplies to restock your bag before you get back in the ambulance, rather than getting back into clean, because you're already in motion. So making sure that they remember that's a priority too, and what those high touch surfaces are. That's really important, because they may not have somebody else reminding them of what that importance is.
Okay, so, and again, I hopefully won't get hate mail from the first responders in the end, but I've heard of that, and we do talk about high touch surfaces in patient care areas, and so to add to Alex's discussion around transmission based precautions and contact, et cetera, there's also the issue of the equipment that's being brought into the home, the ambulance itself. That's all very important. And then Alex, you mentioned, or maybe it was Jill, but this issue around sharps. Obviously there's training on how to, you're injecting patients. Talk to us a little bit about that training. Is that something that is ongoing with EMS in terms of managing sharps and injections and all that goes with that? I'll ask you, Alex.
Yeah, I mean, direct, answer to that question, Sylvia, is, all pre-hospital personnel do get training in the safe management of sharps, and there's, proper repositories, right, for sharps in the backs of these ambulances. As for the EMS agencies for which I provide medical oversight as an EMS medical director, all of our ambulances are clean and disinfected, Sylvia. So I just want you to be clear.
We know they are.
Oh, I'm sure, I'm just...
Yeah.
That's a thing.
Absolutely.
That's a thing. Don't send hate mail. But, it's funny because you don't think about it, right? We talk so much here on the 5-second rule about all things infection prevention and control. And it's important to call out these important people. They're our heroes, right? They come in the middle of the night and helping the public understand infection prevention and control within this sphere. I do want to get to the notion of preparedness, Alex, because talk to us about what that means. I mean, preparedness for me is, obviously what it sounds like. Are we ready for a huge disaster? We've been in the COVID-19 pandemic. There's certainly been epidemics or just mass casualty, right? So from an EMS, EMT perspective, what are some important factors that the public should know about preparedness? What does that mean? Is it about supplies? Is it personnel?
Oh, I think it's about all those things, right, Sylvia? I mean, let's start, with the personnel first. Depending on the type of disaster you're preparing for, I guess, on the 5-second rule, maybe a communicable disease disaster is the right context. And so we talk about a pandemic like COVID-19. So for the personnel, again, the basics of standard and transmission-based precautions are important. How do you take care of patients and protect yourself from getting ill? As it relates to, the application of additional items of personal protective equipment, we'd mentioned that, for caring for a patient that has COVID-19, you'd want to wear an IOSH-approved fit-tested N95 respirator, eye protection, gloves, and a gown. Even caring for patients in the pre-hospital setting. So you need to have some strategies to identify, who among these patients that we might see in the 911 system are at greater risk for having COVID-19, either because they've had a close contact with somebody that had confirmed disease, or they have signs and symptoms of the illness that would suggest they have COVID-19, a fever, a cough, difficulty breathing, loss of taste and smell, being a very specific marker. You can that can serve as a clue for the paramedic or EMT to apply the appropriate personal protective equipment, as an example. And actually, in the EMS community, that strategy we've sort of termed identify, isolate, and inform, which is let's identify the patient that poses a communicable disease threat to me as a responder, as an EMS provider, and then take steps necessary, to isolate, the threat. So apply appropriate PPE on me as a responder, apply a surgical mask on the patient if my concern is that they have COVID-19. And I think, as just alluding to what Jill mentioned earlier, where you're going into people's homes, if you can, and the patient's able, instruct the patient or the family to bring the patient even to the threshold of the home, if that's possible, in an effort to protect responders and maybe avoid their need to go, into the house where the patient's been, and then further expose themselves possibly to, aerosols or suspended droplet nuclei, right, as an example. And so there's education and training associated with everything that I described. We haven't really we talked about standard and transmission-based precautions, but, there's another framework that's familiar in healthcare that we also teach in the EMS community, and that's the hierarchy of controls, right? What can we do to modify the environment to decrease the likelihood that the EMS personnel are going to even come in contact, with infectious bodily fluid, infectious droplets? What work practices and policies can we put in place? Like maybe limiting the number of responders that make patient contact, instead of every first responder and then the paramedics coming in the ambulance and having 6, 7, 8 people make patient contact, limited to the 1 or 2, as a policy to try and decrease exposure to that patient and their potentially infectious bodily fluids. And then, of course, the application of the personal protective equipment. Not only the application of it, but then knowing how to safely take it off. And then, conduct the cleaning and disinfection of the equipment in the workspace, meaning the back of the ambulance, that's necessary so that everything's safe when you go and respond to the next call and manage the next patient.
So that's interesting. Let me stop you there for a minute, because you made me think of a personal. I remember years ago, my elderly aunt, I had to call 911, and to your point, there are about 9 guys that showed up in the room, and it was the EMT and then the paramedics. So I'm going to ask it. Okay, I'm going to take the hit. What's the difference?
Oh, big difference. Yeah.
And no disrespect to the paramedics, but I want to understand that difference, because I'm curious.
No, it's actually, I don't think there'd be any disrespect taken or considered. Each state regulates the practice, right, of EMS. Each state regulates the practice of EMS, but they typically have levels of licensure that are based on a national scope of practice model. So they look very similar from state to state, where an EMT has something, in the neighborhood of 120 to 140 hours of education and training before they're licensed by the state to perform their scope of practice. An advanced EMT, maybe 450 hours of education and training. A paramedic, in the neighborhood of 1,600 hours of education and training. And it's really the paramedic that has the sort of the full scope of pharmacological interventions, right?
Got
The
it.
administration of medications, where the EMTs and the advanced EMTs are much more limited with regards to what kind of medications they can administer. What you see on TV, pre-hospital providers, EMS providers, administering drugs to patients in the out-of-hospital setting, that's largely in the scope of practice of the paramedic. So that's the difference between the three. Now, their understanding of infection prevention measures should be the same. And each of them, whether you're an EMT or a paramedic, you're playing a vital and important role in your emergency medical response system.
Got it. No, that's helpful because I do recall a large number of individuals in the room, and some of which, it was a bit overwhelming. But to your point, Alex, it is about the hierarchy of controls, and we've talked a little bit about that on the 5-second rule. But I think you make an excellent point. I wanna ask you, Jill, because you're an infection preventionist, and what can you share with our listeners about the collaboration among infection preventionists?
One thing that I think we have done really well here, especially during preparedness, during any type of PUI, which obviously means something different to us now after the last 18 months. But anytime
What's PUI?
I'm sorry, person under investigation. I think some people may look at that differently now as we're thinking about a potential COVID patient versus 2 years ago when you may have considered that somebody that may be coming in with potential Ebola or something else. But regardless, when you're looking at these types of events, one thing that we have done really well is including our EMS agencies in our debriefing process. And that's something that we started doing this year, or not this year, with this pandemic. And I think that that's something that is relatively easy to do, depending on if you have a relationship or not with your EMS agencies. And if you don't, this is a great way to start. And if you are doing a drill, or if you have a real patient that you had to actually, break out your PUI emergency card in your ED, do a debrief. If you haven't done one before, including all of your interdisciplinary teams, which we include lab, security, all sorts of different departments that had some sort of play in these events. We also started including those EMS leaders that either responded or had some part in these drills or actual events. And we started forming those relationships that we maybe didn't have before. And that has really helped us here, so that when maybe we did have an exposure or we had an event, we knew who to call. We already had those relationships. And that's how we also started to develop relationships around our healthcare system as well with some of our emergency preparedness leaders. And there's always a place to start. If you don't have any sort of relationship or process, then start there. And there's always a place to build. But that debriefing process can be really helpful, and just fold your EMS agencies right into that.
So let me ask, Alex, Jill's talked about these relationships. I'm thinking about our colleagues in remote or rural areas or low-resourced communities. What has been your experience with EMT, EMS, and the unique needs that they may have in those communities?
It's a great question, Sylvia. I can't speak firsthand because I live and work in an urban environment. The needs of every community, especially as it relates to emergency preparedness, need for access to emergency medical services, it can be equally great in an urban as well as a rural environment. The common wisdom is that resources are short in the urban environment and often in the rural environment too. There's a whole swath of America that actually receives emergency medical services from a very dedicated core of people that are volunteer emergency medical responders. And I want to emphasize their dedication to doing their job well, and the fact that they're volunteers doesn't mean that they don't perform their job professionally. But I think their access to resources is even more challenging, and their access to continuing education and training in order to maintain their proficiency is probably also, more challenging and more difficult. And so as it relates to infection prevention and probably a lot of other, elements or aspects of being prepared to respond to the next, 911 call, I think our colleagues in rural America and the professionals that are responding in a volunteer capacity, they've got an even taller order. And Silvia, I'll tie that back to something you asked about before, and we talked about personnel and their readiness to respond to, let's say, a communicable disease crisis, right, or a pandemic. And some of the challenges that we didn't talk about, but I'll just, briefly list. You asked about supplies. Supplies are clearly an issue. Supply chain and its and its interruption clearly blocks access to critical personal protective equipment and other types of supplies and resources that are needed to safely respond to emergencies. And I can only imagine that the challenges are even greater in rural systems or systems that rely on the dedication of volunteers to access those resources. And one thing that I think is a challenge for every EMS responder, whether they're in an urban, suburban, rural, or wilderness environment, is that this is stressful work.
Oh my
The pandemic makes it more stressful. Working with supplies that are hard to get your hands on, especially PPE, when the supply chain is interrupted, makes it even more stressful. And that takes a big mental health toll on the EMS community, as I think it does, for healthcare providers kind of across that continuum of care. And those are other issues that I think we need to just pay attention to and maybe work collectively to solve. As it relates to preparedness for this type.
Yeah, no, thank you for that, because I cannot imagine the stress, and as we've seen over the course of the pandemic, it's unrelenting at times, and so yeah, thank you for pointing that out. Let me ask you this, Jill. How and why did you get, as an infection preventionist, what drew you to that EMT? What's your story in terms of why you decided, hey, I'm going to go for this?
It's a little unconventional, which, most stories start out that way. But the emergency management coordinator that I was working with at the time, I think he saw that I really liked emergency management, and he kept bothering me to come do a ride along with the station that he worked at. And I kept turning him down, saying I really didn't think that was my thing, and that was okay. And finally, I just said yes, so he would stop asking me. And I ended up loving it. And I went back a second night in a row. And I loved it. And it was a volunteer basis, like Alex mentioned, that a lot of folks do it as a volunteer. So I did IP during the day, and then I joined a night crew. So I did a 7P to 7A shift once a week, and then went right back to work after my 7 to 7 shift ended, and worked as an IP during the day, which was very difficult, with IP jobs, and especially if you had call after call all night long. But you learn to love it. It's something that you may not think that is for you, but it is an amazing group of people to work with, and amazing work. It is hard to do. It's a lot of work, especially to keep up with. But I just ended up loving it, and it's great knowledge to keep hold of through the years.
How about you, Alex? You're a physician, but your focus is in this preparedness. What drew you to this area?
Yeah, Silvia, thanks. It's a good question. So you're right. I'm an emergency medicine physician. I went on to do a fellowship in EMS, or emergency medical services. I think part of what drew my interest is really twofold. One, for a number of emergency medical conditions, there is a continuum of care from the time the patient suffers the insult or injury or becomes critically ill in the out-of-hospital environment, until, they are hopefully discharged healthy from the hospital or to some rehab facility afterwards. And really high quality emergency medical care that begins in the pre-hospital environment is so important for good patient outcomes as it relates to management of trauma patients or ST segment elevation myocardial infarction patients, or stroke patients, as an example. The second part of this question is, why would I become interested in infection prevention? Part of that was maybe good fortune. I'm faculty here at Emory University. I work clinically in the Emory University Hospital Emergency Department. We are neighbors with the Centers for Disease Control and Prevention. And Emory University Hospital developed this biocontainment unit, or high serious communicable diseases unit. And the director at the time, Dr. Bruce Ribner, had reached out to our department because he knew that he needed a partner in pre-hospital care to help bring patients that need the services of their isolation unit to them. And so we developed community relationships and actually developed a specialized education and training so that paramedics with 1,600 hours of education and training, or even EMTs with far fewer hours of initial education and training, could safely manage and transport a patient, even with a high consequence infectious disease like Ebola virus disease, from Hartsfield-Jackson International Airport, if that's where they were, back to Emory University Hospital Serious Communicable Diseases Unit. And we actually, after being involved in maintaining that program from 2002 until the Ebola epidemic of 2014-2016 in West Africa, actually we did move that, first patient in the United States with confirmed Ebola virus disease, which was very gratifying that we could play a kind of supportive role in the good outcome that patient had, and other patients too. But that's my twofold story: my interest in EMS because of the importance of the continuum of care for acute emergencies, and my interest in infection prevention, which began in really high consequence infectious disease, but really is so important in day-to-day EMS operations. So I'm sticking with it. And I'm grateful to have colleagues like Jill Holdsworth, in the community to partner with on these kinds of initiatives.
Well, I'm impressed. I'm always blown away by the guests here on the 5-Second Rule show. And it is so important. These are, I'll just say it, they're heroes because, you're sick, you need emergency care. These are, as you said, many of them volunteers or other trained professionals. So it is important to understand who they are, what they do, and certainly as far as infection prevention and control, what an important role they play. I know we always just scratch the surface here on these very important topics, but this has been wonderful. I can't thank you enough, Alex and Jill, for taking the time to share your story and share your expertise to educate the public and others. APIC certainly supports increased engagement among infection preventionists and the EMT community and the paramedic community. And so look forward to more resources, more collaboration on this important topic. And to get all that information, don't forget to visit www.apic.org.
Thanks for listening to the 5-Second Rule, produced by the Association for Professionals in Infection Control and Epidemiology staff and the APIC Communications Committee, in partnership with Human Factor. Audio tech is Blake Alphin.